Hello, my name is Guillermo Ruiz Arguelles. I am a hematologist. I am the Director General of the Centro de Hematología y Medicina Interna in Puebla, Mexico. And I am happy to share with you some considerations about when to consider hematopoietic stem cell transplantation in chronic myelogenous. As you know, the therapy goals in chronic myelogenous leukemia is turning initially the disease into a Ph1 negative condition, then induce a major molecular response, then go ahead to a deep molecular response, and finally reach this treatment-free remission. This paper here, published in 2013 by Professors Gale and Goldman, addressed the type of treatment that patients with chronic myeloid leukemia should receive in the tyrosine kinase inhibitors era. And they finally considered that the only persons that need an stem cell transplantation are those that are not responding to tyrosine kinase inhibitors, or persons evolving to acute phase despite tyrosine kinase inhibitors. And they also address the point that HSCT should be considered in circumstances in which HSCT is more affordable than tyrosine kinase inhibitors. And this is a critical point that I will address later on. As you can see, the number of transplants done for persons with chronic myeloid leukemia have gone down substantially after the introduction of imatinib. The number is going down, but there are still some persons who need a transplant having chronic myeloid leukemia. These are the indications for hematopoietic stem cell transplantation for year 2019. And as you can see, chronic myeloid leukemia, which used to be a very frequent indication of transplant, is now considered very infrequent. The reasons are multiple. This slide here depicts the type of major molecular response obtained with either imatinib or with second generation TKI, and also the deep molecular response. And as you can see, despite the fact that second generation TKIs induce deep molecular responses, this happens in 60 to 80% of persons. This indicates that despite the introduction of novel tyrosine kinase inhibitors, there are still patients not responding to tyrosine kinase inhibitors, and those are the ones that need probably hematopoietic stem cell transplantation. In the case of chronic myelogenous leukemia, the survival after hematopoietic stem cell transplantation is about the same, employing matched related donors or unrelated donors. This has opened the chances of having a transplant in the United States for persons with chronic myeloid leukemia. Now, the current indications for transplanting chronic myeloid leukemia for 2023 are tyrosine kinase inhibitor therapy failure, probably after employing 3 or probably 5 TKIs. This also is indicated in persons who are intolerant to tyrosine kinase inhibitors therapy, again, probably after trying 3 to 5 TKIs. Persons with high-risk additional cytogenetic abnormalities, and I will show you some data about this. And then also adverse BCR-ABL mutations such as 315I. And again, this is a very important condition, which is no access to tyrosine kinase inhibitor therapy or unable to afford tyrosine kinase inhibitor therapy. In resource-constrained settings, we have become experts in this last point, which is the lack of access to afford tyrosine kinase inhibitor therapy, And I will elaborate a little bit more about this particular point, which has been present as an indication since the paper published by Gale and Goldman in 2013 up to now, 10 years later. These are the additional cytogenetic abnormalities that may indicate the need of a hematopoietic stem cell transplant in persons with chronic myeloid leukemia, which are complex carrier trisomy 19, marker of chromosome inversion 9, deletion 20, and the others that you can see in the slide. Now, as I told you, in resource-constrained settings, such as the country in which I live, we have become experts in the one of the indications of hematopoietic stem cell transplantation in persons with chronic myelogenous leukemia. So, both in 2013 and 2023, as I said, circumstances in which hematopoietic stem cell transplantation is more affordable than TKI, and no access to or unable to afford tyrosine kinase inhibitor therapy. And again, this is the area in which we have turned into experts, because these are the current conditions of our practice of medicine in constrained circumstances. In year 2002, we published this initial information about transplant program that we started in our country using very affordable drugs that will cut down the expenses of hematopoietic stem cell transplantation. And the initial indication in this particular point was chronic myelogenous leukemia. Later on, we published this paper about the early referral for reduced intensity stem cell transplantation in patients with Philadelphia positive chronic myelogenous leukemia. This was a prospective multi-center story of the Latin American Cooperative Oncohematology Group, and we proved that the results were adequate, employing this reduced intensity conditioning and conducting the transplant on an outpatient basis. Later on, in 2008, we went ahead with this paper in which we described the therapeutic choices in patients with CML living in Mexico who would receive either tyrosine kinase inhibitors or stem cell transplantation. And as you can see, the survival of this person was about the same, employing stem cell transplantation or tyrosine kinase inhibitor. And it was interesting to find out that the median cost of each allograft in our experience was $18,000, which is an amount that is enough to cover 180 days of treatment with imatinib at 400 milligrams a day. So this is a paper that we published in 2008 and which is still valid, which indicates that the cost of hematopoietic stem cell transplantation is substantially lower than the treatment with tyrosine kinase inhibitors in persons with chronic myelogenous leukemia. And in these conditions, choosing the hematopoietic stem cell transplantation may be a better option for persons with chronic myelogenous leukemia. This is unfortunately true for most patients living in underprivileged circumstances in which persons live in low or middle income countries. So the cost is $18,000, and this is now for 180 days of treatment. So the cost considerations favor SCCT as the once only procedure for a lifelong treatment with an expensive drug represents an excessive burden on resources. So according to this information, we recently published this review the treatment of chronic myelogenous leukemia at an environment with limited resources. And these limited resources are present in low and middle income countries. We also made this recent review, 2017, concerning insights into the management of chronic myeloid leukemia resource poor settings. This is a Mexican perspective, and we describe in this particular paper the experiences in persons with chronic or myeloid leukemia in low and middle income countries, comparing allohematopoietic stem cell transplantation versus tyrosine kinase inhibitors. And as you can see, in the patients with allogenic hematopoietic stem cell transplantation or tyrosine kinase treatment, the overall survival is, in our experience, about the same. Whereas in other places of the world, such as here in China and some other places, the results are a little better for hematopoietic stem cell transplantations than for imatinib, as you can see here. So this supports the idea that hematopoietic stem cell transplantation is still a valid option to treat persons with chronic myeloid leukemia in circumstances in which the treatment is more affordable, employing hematopoietic stem cell transplantation than the tyrosine kinase inhibitors. Now, some things have changed since the introduction of tyrosine kinase inhibitors, and if you use them to compare them versus HSCT, we have to accept that tyrosine kinase inhibitors have become more affordable, that we have now generic tyrosine kinase inhibitors, that HSCT has become more safe, and persons with HSCT develop nowadays less and less severe forms of graft versus host disease. So graft versus host disease has become less frequent, and graft versus host disease has also become less severe. However, in developing countries or low and middle income countries, as they should be called now, HSCT is still a more affordable treatment option for persons with chronic myeloid leukemia. And this is a picture of the world, and in green, you can find what we call the low and middle income countries, which represent 82% of the inhabitants of all the world. So we have to accept the fact that in these countries, in which live nowadays 82% of the inhabitants of the world, the hematopoietic stem cell transplantation procedure is a valid option, probably more adequate as far as economies is concerned than the employment of tyrosine kinase inhibitors. And I think this is something that has to be taken into account when deciding the treatment of patients living in these areas, in which you have to very carefully consider HSCT or the employment of tyrosine kinase. This is my last slide. This is my electronic address, and I would like to share with you several ideas or papers about what I just have tried to describe of the employment of hematopoietic stem cell transplantation in persons with chronic myelogenous leukemia, mainly in those living in low and middle income countries. I thank again the organizers of these lectures, their kind invitation to participate with you. And I also thank the attention that all the persons that have been able to see this recording are now present. Thank you very much.